much. It's very difficult to follow such good talks. I'll try and impress everybody by making my talk short. I think at this hour of the day, that's the best you can do for a talk, because always the most interesting part is the conversation at the end. I think we should all remember that the person who likes to talk the most is always the speaker. So our outline: why is SAVR preferred for small annuli? I think we should look at the harms of patient prosthesis mismatch, how aortic root enlargement can avoid this, discuss which situations we should perform aortic root enlargement in, how do we perform the procedure, is this procedure safe, and what are the implications for a future valve-in-valve. So what's the problem with the small annulus? Size matters. Having grown up in Washington, D.C., I like this photo of the Bullets, Washington Bullets. They're now called the Washington Wizards. They had the tallest player and the shortest player in the NBA. All right, so nobody wants patient prosthesis mismatch. We look at this, everybody knows to look at the EOA over the BSA, and we see all the bad outcomes. And the valve companies all know this too, right? This is a brochure from a company, right? Looking what are the negative clinical effects of PPM, decreased post-op cardiac index, decreased late survival, the list goes on and on. These are all things that we don't want our patients to have. So we have sizing charts, and we look at them. I look at this frequently to see, what size valve does my patient need? And we don't want to be anywhere near being borderline, so we want 1 or 2 valve sizes above what's going to get us in the green zone. And so most patients will do well with a relatively smaller valve until you start getting to a BSA of about 2.2. So what does a BSA of 2.2 look like? I think it's important for all of us to do the math. And when the patient walks in the door, we know who's going to be at risk for PPM, right? We have especially females, smaller body habitus, extra kilos, 100 kilograms, 175 centimeters tall, or 110 kilograms, 155 centimeters tall. And I did a case like this about 2 weeks ago. So when you see a patient whose body type is more along the cube size, then you need to be aware. So this is the outcomes of replacement with the Edwards Magna valve, 19 millimeter valve in 447 patients. 54 of them received a 19 millimeter valve, and mean follow-up of 4.9 years, maximum 15.4 years. Echo data available pre and post. And when we look at this, we know that the 19 millimeter valve had slightly higher gradient and more patient prosthesis mismatch. However, in this study at least, there was no difference in overall survival, cardiac-related mortality, or MACE. Now, that's not saying that we should go and implant 19 millimeter valves in everybody, because we know that from multiple prior studies, patients have worse outcomes when they have PPM, either after SAVR, after TAVI, and some studies have looked at both. But however, we need to look at the following problem, right? More patients want biological valves. We heard about this. I had a lady come to my office a couple weeks ago. She had a biological valve implanted at age 50. It has now deteriorated. She's 60. So we have to discuss, are you going to want a biological valve again? Are you going to want to transition to a mechanical valve now that you're older? What are we going to do with the first valve? Can we do a valve-in-valve? It's all these issues that we talk about. But I think we need to be careful with biological valves in younger patients. So I think for when we look at our guidelines, this is 2020 ACC-AHA. Let's keep in mind that for the time being, for asymptomatic patients, let's be honest with ourselves. When there are no symptoms, all roads lead to SAVR, pretty much, with few exceptions. When patients under 50 years old, we're definitely going to be placing a biological valve. And almost definitely a biological valve. We're going to be placing mechanical under age 50 and a biological over age 65. In between is a bit of a gray zone. The European guidelines, as we said before, look at TAVI for those over 75 who can do transfemoral. I think it's important in the equation to not forget that the good outcomes of TAVI depend upon it being done transfemoral. And in general, in most of these trials, these are not patients who are having balloon valvuloplasty of iliac vessels in order to get their TAVI done. These are patients who from the get-go had good femoral vessels. So what are the key steps for getting many decades with a biological strategy? The most common strategy probably for most of these patients is going to be SAVR and then TAVI and SAVR, but it's also possible to do SAVR, then redo SAVR and TAVI after that. So TAVI as first valve, implant followed by TAVI and TAVI, or TAVI explant is also possible, but it's usually not the best choice. All the studies that we've seen being mentioned previously show that there's a high mortality rate for open surgery after a TAVI procedure, 15 to 20% in most series. So the first surgical valve, we want it to be as large as possible, especially keeping in mind that we're going to possibly do a TAVR into it later. When you look at the commercials that the valves put out, it's very interesting to see this, the Medtronic valve. Why did only one TAVI valve have better hemodynamics than SAVR? There's many reasons you can speculate. And so you see the Evolute low risk at 3 years, and obviously we have newer data than this that's come out. But when you look at the PARTNER 3 trial, I think it's interesting. When you dig back into the appendix that nobody looks at, there were 21 patients that had root enlargement in the PARTNER 3 trial. And I think it's always interesting to look at the nitty-gritty of all these trials and to say, hey, maybe that gave surgery an advantage in this trial. And so if you look at the gradients here and you look at the EOAs, et cetera, it looks like the surgeons didn't do too poorly in this trial. So I'm going to go through this really quickly so we can have a discussion at the end. As I said, I promised to give a quick talk. So this is the anatomy of the aortic root as we all know it. And there are a variety of methods for doing an aortic root enlargement. Manugian, Nix, the relatively newer Yang technique, which is kind of a modification of the Manugian. There's a Roscano. There's multiple other techniques involved. So this is one of the nicest videos I found. I don't have as nice a video as they made out of Toronto, but you can see it's not that complicated. And I think the main barrier for most surgeons to do this is that if you've never seen one, you're probably not going to do one. But if you've seen one, you know that it's relatively straightforward to open the annulus, sew in a patch, and then it's just a matter of someone taking you through your first one and then see one, do one, teach one pretty much for these cases. So this is a case that, one of the more recent cases that we did here at Hygeia. So you see the similar thing. The aortic annulus has been opened. We have sewn a biological patch. This is bovine pericardium into the root. And then you can see that the bovine pericardium also gets used in order to close the aortotomy. The interesting thing about this technique is what the safety of this procedure. And there have been a lot of studies done on aortic root enlargement. This is a 2022 meta-analysis of 9 studies, over 200,000 patients with over 7,000 with the root enlarged. And you can see that SAVR with aortic root enlargement, they had pretty much the same safety. There's no difference. And also, when you look at matched patients, and this is important to interpret this correctly. So I think the issue is here that these are comparing patients who just had a straightforward SAVR. They already haven't had an annulus big enough for an appropriately sized valve, and patients who needed an aortic root enlargement, right? So these are patients who had a smaller annulus. When you do an aortic root enlargement, these patients now go to being toward like their colleagues who had a large annulus towards their peers. So 809 matched patients from Ontario showed no difference in survival, CHF readmission, or aortic valve reintervention after having their aortic root enlarged. This is one of the more interesting recent techniques, also showing that depending on the way you do it, a lateral left-right commissural root enlargement may reduce your risk of coronary artery obstruction when you go to do your future TAVR and TAVR. I think a lot of nice studies have come out of Michigan, and out of Michigan they've shown that when they did a retrospective analysis, about 50% of their patients would not have been candidates for TAVR and TAVR. So we give patients one TAVR. If we say this fails, yeah, just come back, we'll just do another one. In their analysis, that was applicable to only 50% of the patients. We have newer surgical valves that are designed for valve-in-valve with a surgeon contribution for some of these. And I think a lot of us are now doing these valves minimally invasively because what patients want is a big valve through a small incision. I'm not going to belabor the point. Thank you very much for your attention. I tried to keep this brief so that we would have, I'm 5 minutes early, so we have a little bit of time to chat. So I think the conclusion is bigger is better for valve size. Thank you very much.
Very nice and insightful topic and presentation. Don't you think that despite this data, we do perform much less aortic root enlargement than what is needed, and why is that?
Yeah, 100%, and I knew this question was going to be asked because this is what's asked every time that I give a similar talk. So I'm going to turn it square back to you and say it's all your fault entirely. It's the fault of the cardiologists. Come and demand this. You have a lady with a small aortic annulus, you've done her echo, and you know you're not sending her for TAVR, you're sending her for an open operation. So we can't do this. So you should find a surgeon who can do this, and you should demand it. It's the same thing that people tell us about mitral valve repair. They say, Greg, your slides are fantastic, but I send my patients for mitral valve repair and they come back with a mechanical valve. I think you need to select your surgeons. I think you need to demand it. God bless, Greece is a country that has the highest ratio of cardiac surgeons to population in Europe. Did you know that, Dr. Reardon? So there's no shortage of cardiac surgeons here. You can find people to do this for you. If they're not doing this for your patient, and your patients are coming back with small valves, I have a couple extra cards that I can hand out at the end of the session. I say this jokingly, but the point is we can do it. We should be doing it more often as surgeons. I'm not saying that it's for every patient, but I think we need to demand more of ourselves. And I want you as a cardiology community to put the pressure on us to do it. The patients need to come and ask for it. Otherwise, most surgeons, I'm not going to say whether I include myself or not, we may not want to do the extra work, but there's a demand for it. Just like now you wouldn't send someone for a CABG without demanding that they get a lima to the LAD, this should be standard that when you have a small aortic root, you're going to get an enlargement.
It's also changed, Greg, with the Y annuloplasty. So we used to do Nicks and Manugians. You could go up one valve size. Sometimes you could force it to. You do a Y, always 2, usually 3, and Bow often goes up 4 sizes, which I think is a little crazy, but in the Evolut low risk, my annual enlargement rate was 5%. In my practice now, it's 46% because of what we can do. And we never let a woman leave with less than 23. Never let a man less. That's the bottom that we'll go out with. 19 and 21s, we just don't even use them anymore.
Bad idea. Yeah.
Yes, please.
So, Greg, in general, I agree with you that the larger, the better. And procedures such as Ross procedures, we should be strong advocates for. But I don't think we should get over enthusiastic about it to the point that patients may end up being hurt by somebody that's not experienced in root enlargement. Yeah. And, there is a Sweetheart series published in JACC 6 months ago of 16,000 patients followed for 15 years. Half of the patients had PPM. Now, 48% were moderate PPM and only 3% were severe. And the 15-year survival difference between patients with moderate PPM and no PPM was 2 months.
Yeah.
So I think that moderate PPM is not as bad as we're being led to be, and it's predicted PPM, not measured PPM. Right. That's the most accurate in terms of doing it. So in general, I agree with you, and I think that if the plan in a patient, a younger patient, is to put in a biologic valve because they can get a valve inside it, then we're doing a disservice if we're not putting at least a 23 in. Yeah. Independent of whether it's PPM at the initial one or not.
Fantastic. Thank you very much, Dr. Mack, for your comments. And I think, having Dr. Reardon, Dr. Mack, Dr. Kilic, and all of our guests, local and international here, this is what this meeting is about. So, we're very excited to hear everybody's input. I think that, part of the issue is, as I said, with planning, that you don't want to have a 19 millimeter valve in a patient and then tell them, yeah, we're going to do a TAVR down the road when this fails, because we know that's going to be exceedingly hard, or you're going to end up with huge valve gradients, which are things that we don't want. So obviously, in the country that invented the term of everything in moderation, we wholeheartedly agree with you. Pan Metronariston.
Dr. Chrysocheris?
Yeah, I wanted to ask, should CT angiography of the aortic root be mandatory also for patients referred for surgical aortic valve replacement?
Yeah, I don't know whether it should be mandatory, but I do it very frequently. When there's any discussion, as you know, Mike, I do, both. I'm comfortable with both operations. So patients frequently come to see me, not predetermined. They come and see you. They know they're going to get a TAVR. They see somebody else who doesn't do TAVR. They know they're getting a SAVR. people come to me and we discuss both options. And there are pluses and minuses. And if they're still on the fence while they're trying to decide, I say, let's get a CT scan. Let's look at your annulus. Let's see how things are going to be for SAVR, for TAVR. Let's look at your groin vessels. And this may sway you towards one operation or the other. But I think 100%, I don't know if it should be mandatory, but I think it's definitely good practice. The more information you have, the better decision making you can do.
Very much. I think it's time. Dr. Dardas, you have a comment on this
Yes,
section?
congratulations, Greg, about your talk. I just want to ask you, in a lady who's got a small annulus, would you prefer surgical self-expanded valve, Percival, something like that, rather than doing a root enlargement?
I'll tell you, I think that, Percival, I think is a good valve, and you need to customize it. I would say that I use the spectrum of most valves that are available, including SAVR and TAVR valves. I don't want to knock or overemphasize any one valve. I think it's important to look at the patient and their characteristics. I think there's definitely a role for Percival, and I think that a lot of surgeons use Percival instead of performing an aortic root enlargement. I don't think it's fair to say that putting in a Percival obviates the need for surgical root enlargement, if that's kind of what you're getting at.
Yeah. I agree with you. Thanks a lot.
Thank you very much.
If you ever take a Percival out, they are really hard to get out.
I've only removed the Percival out when it's fresh, only a few days in. When it's been in there for a long time.
Once they heal, they're horrible.
Yeah.
They're just terrible.
Thank you.
Thank you very much, all of you.